Welcome, everyone. I'm glad to see all of you coming despite the big hockey game tonight. And I'm really grateful for tonight's speaker being flexible, recognizing the importance of the Battle of Alberta in Alberta. And I'd like to welcome you all to tonight's, or I guess this evening's, CMN Collaboration Forum, Gender and Chronic Pain, Women's Experiences Through an Intersectional Lens. Our speaker is Dr. Fiona Webster, who I'll introduce more formally later. Next slide. As usual, we have our housekeeping. I'm Kathy Scrimshaw. I'm a family doctor down in Pincher Creek, and I have two disclosures. I'm a part-time paid employee of the Alberta College of Family Physicians, as well as a part-time employee of Alberta Health Services. Lori Montgomery just mentioned that she didn't know there was a hockey game tonight. Our moderators today are Maya Mudrick and Carrie McNabb. Dr. Leah Phillips and Jared are away today, and they are also paid employees of the Alberta College of Family Physicians. And we do receive financial support from the Alberta College of Family Physicians through a Health Canada Substance Use and Addictions Program contribution. We don't receive any in-kind support. And our usual housekeeping: to capture your attendance, please click the survey link in the chat to enter your name and your email. We will be using the chat log to collect questions, and we would like to have a Q&A at the end of the presentation. I'll be watching the chat if you put them in during the presentation. You can also, at the Q&A, use the raise hand feature to verbally ask a question. And as I said, a dedicated time for Q&A is at the end. It would be great if you can fill out the evaluation survey at the end of the session as well. And so now I get the great pleasure of introducing Dr. Fiona Webster. She is a critical sociologist and an associate professor in the Labatt Family School of Nursing at Western University, and holds a cross appointment with the Institute of Health Policy, Management and Evaluation at the University of Toronto, where she is also an academic fellow with the Center for Critical Qualitative Health Research. She successfully led many tri-council funded interdisciplinary research teams with a particular focus on applying sociological approaches to understanding and improving care, with a particular focus on chronic pain and marginalization. By turning a sociological eye to the challenges of providing chronic pain care within parameters currently delineated by the Canadian healthcare system, her aim is to identify structural and ideological components of contemporary healthcare that might be amenable to change. And it was interesting, I was telling Fiona today, I attended the O'Brien Institute research seminar on COVID, and the very first talk was the impact of COVID and the pandemic on women and men and the gender differences. And not surprisingly, the direct effect was felt more by men, but the indirect effects affected women, and they will be studying that more fully. So I'm delighted to turn this over to Dr. Webster, and I will mute. So thank you very much for being here.
So here we go. So thank you very much, Kathy, for that lovely introduction. It's a pleasure to be here today and to be sharing some of the work my team and I have been doing around gender and chronic pain. In terms of the organization of the talk today, I thought I'd start by providing a little bit of framing of the concepts of sex, gender, gender norms, and intersectionality, and then move on to share stories from an ethnographic study we've been conducting looking at the experiences of chronic pain and marginalization. And the analysis I'm presenting today is still very preliminary, so this is very brand new. You're the first audience hearing it, and I'm really looking forward to your thoughts and feedback. So I have nothing to disclose or declare. We did create some learning objectives for today, so I hope that I'm able to meet these 4 objectives. And the idea was that by the end of the session, people would be able to recognize the difference between sex and gender, to have a better understanding of why and how gender matters in the context of chronic pain, to learn about intersectionality and be able to apply it to women's experiences of chronic pain, and to begin critically reflecting on the experiences of women who've experienced gendered aspects of pain. So, like any good qualitative researcher, I always like to begin by positioning myself in my work, which is something that I always try to do. So as Kathy said, I'm a sociologist in the School of Nursing at Western. I was previously with the Department of Family and Community Medicine at University of Toronto. And I've really spent my career working alongside clinical colleagues on the ground, and trying to conduct research that addresses sort of real problems that have both clinical relevance and relevance for patients and family members. In relation to today's talk, I'm a cisgender, heterosexual woman, white, middle class. I'm a feminist. I've studied feminist theories during my PhD training at U of T. And when we talk about intersectionality, I'm going to be discussing how we don't have just one fixed identity, such as I am a woman, but in fact, several intersecting identity with memberships in different social groups at different times. And we'll hopefully begin unpacking together why that matters. So let's start with sex, gender, and gender norms. So sex, gender distinctions, I think, are fairly well understood at this point, but in the not too distant past, it was considered that gender had a direct correlation to biological sex, meaning that biological males were masculine and a certain definition of what masculinity was, and biological females were feminine with a certain definition of what that looked like as well. Now we know these are separate things, with sex being the biological construct of who we are, so chromosomes, sex organs, hormones, etc., whereas gender is completely socially constructed. We know that it's changed historically, it changes geographically, it changes by culture. So gender is the sort of social constructed identity we take on in terms of our social roles, our identities, our behaviors. And then there's gender norms, and gender norms are culture-based, and they really express what it is that we, or how it is we think that men and women should behave. So gender norms, I think, are really important and really underlie a lot of the biases that we see and experience. And it's the gender norms that reproduce such beliefs as the idea that men are superior to women, this, for example, that so-called masculine traits are being more highly valued. So, we've been taught to think of things like independence and strength as being masculine traits, and nurturance and sensitivity as being feminine traits. So these are the kinds of biases that permeate not just our lives, but really they're evident, they've been shown to be evident in most healthcare across different diseases and different settings, but I think they take on a particular form in chronic pain. And there's three types of gender bias I wanted to sort of bring forward today. These are gender blindness, seeing hegemonic masculinity as the idealized norm, and andronormativity. So gender blindness or gender blindness is essentially when we fail to recognize sex or gender differences. So think, for example, about research where only men or mainly men have been enrolled in research trials for certain medications. And then, those medications are brought to treatment for both men and women. We know that, what works for men doesn't necessarily work for women. Hegemonic masculinity as the idealized norm refers to a particular type of masculinity, usually associated with white middle-class men from the dominant group. And this becomes the ideal man that gets projected through, television shows and media and, passed down through families. And then all men get compared against that norm and usually found lacking. And andronormativity, another sort of important type of gender bias, refers to when men are referred to as the main reference group and women become the negative case. So, for example, think about how we often refer to women's heart attack symptoms as atypical, with the assumption being that somehow men's symptoms are the norm. Now, as I said, this is particularly, all of these issues become particularly relevant in the sort of chronic pain field. Chronic pain has been and still is largely dominated by biomedical research, meaning that the emphasis is on sex and understanding sex differences. And there's really been a sort of broad ignoring of gender differences. And this has profound implications for both men and women. So just some quick stats to sort of back up my claims here. We know, for example, that men are disproportionately represented in opioid overdose deaths, but not in overdose deaths relating specifically to prescription opioids. We know that Canadian women are more likely to live in poverty, and that trend is even more pronounced for transgender women, also older women. And finally, many women generally have greater caregiving responsibilities than men. And these responsibilities can often take precedence over women's own needs, both at their own direction and by the sort of obligations we put on women. At the same time, men are disproportionately employed in manual labor professions, and they suffer very high rates of workplace injury, leading to chronic pain. So you can see here how chronic pain research is in serious need of critical engagement with these social or gendered aspects of chronic pain. Now, there's specific ways in which gender applies to women as well in this field. So women tend to be overrepresented among those with chronic pain conditions that aren't straightforward in their diagnosis or treatment. So think about fibromyalgia. In addition, women are more likely to be prescribed medications for anxiety and depression rather than for pain medication. And this is also a highly racialized issue with members of the Black community, both men and women, who have been sort of denied opioid pain medication to the point where some Black scholars have labeled the opioid crisis as a white Western crisis. Meaning that it was elevated to sort of have such sort of widespread prominence in the media and in our thinking because it largely applied to white and often middle-class people. And thinking about gender norms, while this is sort of interesting to me, while more women are diagnosed with chronic pain syndromes and it's more socially acceptable to show pain, for women to show pain, at the same time, women's pain reports are taken less seriously. They're frequently dismissed. Their pain is discounted as being either sort of psychologically based, exaggerated, or imagined. So you think about the term pain catastrophizing. And a lot of research scholars have shown the association between the concept of pain catastrophizing with hysteria. So it's this notion that, you know, women in particular will somehow over-exaggerate or imagine their pain. Now, within the sociological literature, chronic pain is positioned very much as a gendered experience so that it's taken up as being informed by inequities and stereotypes. And the argument is that chronic pain has to be contextualized within the socially expected sets of behaviors, norms, and roles of being a woman. And of course, there's a vast amount of sociological analysis on the gendered experiences of health in general, with the underlying argument being that medicine upholds patriarchal constructions of and control over women's bodies. So this informs a lot of the sociological work on chronic pain as well, such as the specific struggles women face when it comes to living with and treating chronic pain and the social processes that inform how women are treated. So as an example of this, Broom and her team in 2015 analyzed the diaries of women living with chronic pain and found that women talked a lot about feeling delegitimized and unworthy in the face of their pain. Bendelow is another key researcher whose work has offered us important insights on the relationship between pain, gender, and culture. And another researcher, Werner, and her team narrowed in on the experiences of women by considering how accounts of illness are shaped by cultural discourses of gender and disease. And Werner and her team claim that while women, quote, negotiate a picture of themselves that fits within normative biomedical expectations of what illness is and how it should be performed, end quote, there's evidence of how women offer subtle resistances within and throughout their stories and reject those stereotypically gendered medical discourses of the crazy and weak woman. So these are just some of the ways in which in the sociological literature on chronic pain, we see how gender is taken up. However, it's not enough to just take a gendered lens, as women's experiences, as I said at the outset, intersect with racialized identities, socioeconomic class, sexual orientation, migration status, and other social characteristics. And so now I want to talk just briefly about intersectionality. So intersectionality was originally developed by Beverly Crenshaw in 1989. It was a theory that was brought forward as a critique of second wave feminism, which was seen as being a sort of white and middle class movement. And Crenshaw sort of drew our attention to how the category of woman as an essentialized category was actually inaccurate and misleading, because our gender, of course, is mediated by other and intersecting identities that we hold, such as race, class, sexual orientation, sexual identity. Further, identities are not fixed, but are historical, relational, contingent, and ambiguous. So our identities shift across time, and they shift in terms of who it is we're interacting with. So let me give you a really easy example of this, of how identity is relational. So when I'm standing or sitting here speaking with you today, I'm a professor, a sociologist. When I'm at home with my kids or I'm in the grocery store shopping, I'm just a mom to people. And people around me respond to me differently, and I act differently as well. So this is the ways in which our identities are in fact relational. And you can think about how your own identity shifts as well in your own lives. And knowing this and thinking about sort of intersectionality, the argument has been, helps clinicians to enhance their own self-awareness and to find commonality with patients rather than to always assume differences. So to begin moving away from thinking in binaries such as doctor and patient or nurse and patient, but rather recognizing that physicians and patients hold multiple identities, and some of these identities they will hold in common. Now, there have always also been important critiques of intersectionality that I want to bring your attention to, because I think they're particularly important at this particular time in history. So the first critique is that intersectionality was a misunderstanding of feminist history and sort of feminist theory, but leaving that aside, I think that's less relevant for us. I want to focus on how intersectionality has this overwhelming focus on the individual. And naming off a list of our privileges, as I did in the beginning of this talk, simply states the existence of an unequal society, but of course it doesn't do anything to help us understand it, or more importantly, to challenge it. So when we focus on ourselves or others as individuals, we're ignoring systemic issues. So we're ignoring politicized and systemic issues of oppression. And this is an important point because sometimes if we get stuck on focusing on our individual privileges, which has a place and is important, it doesn't help us to think about how can we shift these systemic inequities. So doing that requires more than our goodwill and our good intentions. It requires political action. So with that very sort of quick overview of some of these key concepts, I want to move to sharing with you some findings from my research program. It's COPE 123, Chronic Pain Ethnography, and I've been funded since 2014 by CHR for this sort of rather large program of research that takes up the study of chronic pain and marginalization from various standpoints. So I started in the standpoint of primary care physicians, and then I moved on more recently to begin to speak to people who suffered from both chronic pain and marginalization. So I use a type of research approach known as institutional ethnography, or IE. And IE always begins within someone's standpoint, and standpoint is understood as being different than experience because the notion of experience individualizes. So it's finding out, like, where is your standpoint within social organization? So it's a way of getting into people's experiences and then helping to link how those experiences are hooked into the social systems in which they live. And there's a particular focus that I take up in my work on work. And IE has a particular understanding of work as not being things that we do for money, so not paid labor or employment, but all the things that people do to sort of manage their lives, and in this case, to manage lives that are beset by chronic pain and forms of marginalization. And when we were recruiting people for the study, we realized that we'd ended up with 22 stories from women. So in addition to our main analysis, of course, we were compelled to sort of apply a gender analysis to this work. I just want to also recognize here at the very bottom of this slide, my colleagues. It's a wonderful sort of multidisciplinary team that I work with, and I'm going to be sharing with you quotes from participants, and I actually have their consent to use audio clips so you can hear them talking in their own voices. And the interviews were conducted by Dr. Laura Conway, who's a research associate working with me, and she really did very beautiful interviews for this study. So we have 5 preliminary themes I'm going to talk about today, and really we're at a descriptive point. So, as I said, this is very new. I want to say a few words about how we understand people's experiences in an IE study. So again, people's experiences, their standpoint, are just an entry point, not the end point of the study. We're looking not for any kind of absolute truth, but what I like to call narrative truth. And our line of inquiry is aimed at understanding how people's experiences are organized historically, through policy, through law. So here are the 5 interrelated preliminary themes that I'm going to share today: gendered poverty, intergenerational poverty, and it's linked with abuse and trauma, stigmatized pain conditions, and specifically the ways in which stigma is gendered, relational aspects of pain management, and mothering as a specific form of relational experience. So the first theme we identified relates to gendered poverty. As I mentioned at the outset, Canadian women are more likely to live in poverty, and this is often shaped by their experiences of violence, trauma, and single motherhood. And it also introduces very specific forms of work that women have to take on. So we start with Lisa. Lisa lives with 2 neurological conditions. Due to a car accident, her financial situation changed drastically when she left an abusive marriage. And as we know, this happens frequently to women, and in fact, it's often a deterrent for women leaving abusive relationships. She applied for disability insurance after her pain became too much for her to work. She says that her pain is unresponsive to most medications, and the ones that do work for her are not covered. So in fact, she tells us 90% of her pain management plan is not covered. So in this quote, she's going to talk about how leaving her marriage has affected her financial situation. And in Lisa's case, her management plan that she can no longer afford hasn't actually been changed very much by her physicians. So she's really sort of stuck between sort of a rock and a hard place here. Uma offers us another insight into this. So Uma also talked about an abusive ex-husband who, in her case, didn't pay her child support. She's in her 30s. She lives in subsidized housing with her son. She struggled with chronic pain for most of her entire life and lived through a traumatic childhood. She has trouble making ends meet due to sort of various factors. Living in BC, first of all, which is the most expensive province in Canada, having to pay out of pocket for her pain management and not being able to earn enough money due to her chronic pain. So in her case, and this actually isn't evident in this quote, her poverty has meant that she's had to prioritize rent over food. And this is a very difficult decision that many women living in poverty have to make. And Uma has gone hungry so that her son can eat. And here she talks about having to mediate finances with an abusive ex-partner. The last sort of participant for this theme that I wanted to share is Sophia. Sophia is a single mother in her 50s. She lives with multiple physical and health conditions. She's been unable to work due to her pain. She relies on disability assistance, which provides inadequate amounts of funding for her to maintain a decent quality of life. She also lives in subsidized housing. She also struggles to afford the cost of her prescribed alternative therapies. Sophie claims doctors don't take her pain experiences seriously and tells us that she feels her doctors are assuming that she has access to resources to manage her pain. She feels her pain is at least partially related to her traumatic childhood, in addition to the stress of being a single mother and the work of, as she puts it, having to do everything by herself. And so here she's talking about sort of mothering through poverty. So that's Sophie. And it's hard to find the right clips to share from these very, very complex stories, but I hope you're beginning to get a sense of some of the very gendered issues of poverty. Related to poverty, there's, of course, intergenerational poverty, and it's often intergenerational poverty, intergenerational abuse, intergenerational trauma, intergenerational mental illness. And for this theme, I have an extended quote from Sophie again, because there's a lot of, this is such a clear example of the ways in which poverty, mental illness, pain sort of move from generation to generation, and also in Sophie's case lead to extended childcare responsibilities that for her are now leading her to be taking care of her grandchildren as well. So here's Sophie talking about that. One of the most striking things about Sophie's story is that despite the sort of profound sort of structural systemic issues that are contributing to her situation, she often moves to talk about herself in medical terms that completely overlook the situation that she's living in. So she'll talk about herself as having been potentially a pain catastrophizer. And yet when you listen to the story, it is a catastrophic story in many ways. So the third theme that I wanted to share is around stigmatized pain conditions and the way in which they become gendered. And pain, as we already know, is a stigmatized condition due to its subjective nature, and in biomedicine is organized around the notions of objectivity. And so chronic pain really presents a particular kind of challenge for medicine, and is so eloquently stated by Elaine Scarry: to have pain is to have great certainty, to hear about pain is to have doubt. And here we find that stigma takes on a particular form in the case of women. So Poppy in this clip is discussing her experiences with doctors who don't believe in the legitimacy of her pain, as well as doctors who focus on her weight in a certain way. And she attributes her weight gain to not having access to good quality food, which for her is unaffordable. Poppy's in her 30s. She also endured an abusive childhood. She lives on social insurance as a person with a disability. which she says was a very difficult application process, and that's something that we're analyzing in a different paper. And she's been currently waiting to get into a pain management clinic for 2 years. So here's Poppy. So that is, there are so many issues embedded in this quote, as I'm sure that you heard. But here we just want to focus on the particular forms of gendered stigma that occur for women. So the fourth theme is the relational aspects of pain management. So pain management for women is relational, which is to say the context in which they live is influenced by their relationships within their families. So in the next two accounts I'm going to share, you're going to hear women talking about how traditional gender norms around the appropriate relationships and behavior between men and women explain why, for them, their husbands can't support or help them with their pain management. And we definitely see this in other disease groups as well. There's a wonderful study by Jan Angus at the University of Toronto from several years ago. Jan was looking at why women don't do as well with cardiac rehab as men do. They have worse outcomes than men. And she made the argument that home is where the heart is, meaning that when women are at home allegedly resting and undergoing cardiac rehab, then in fact for them, home is a place of work. So it's not the place of rest that it often is for men. So two women here, Hannah and Violet. So in these stories, we hear quite clearly gender norms and how they influence the way women accept certain behaviors within their relationships. We hear how the needs, thoughts, and emotions of the women are set aside to ensure the well-being of their partner. They also both speak protectively of their partner, with Violet saying, I don't want to make him sound like he's not a good person. In Hannah's case, she's not even discussing her chronic pain with her husband because she doesn't want to upset him. So these relational aspects of pain management really sort of highlight the ways in which women's lives are not independent, but deeply embedded in relationships and responsibilities for others that are largely unrecognized in chronic pain management literature. And of course, mothering is a particular type of relationship with profound importance for women. It's also a relationship that's heavily laden with discourses and assumptions about the so-called good mother, which so many women internalize and which significantly impact their experiences of pain and their emotional and psychological well-being. So Natasha, who is our final clip, talks here about the guilt she feels because her chronic pain does not always allow her to, as she puts it, do what the other moms can do. So here's Natasha talking about having chronic pain and being a mother. So Natasha's experience was very representative of the stories we heard from many women around pain and mothering, that they felt that it was interfering with the type of mother they felt that they wanted to be and should be, and also interfered with their ability to practice self-care. So how do we put all this together? So as mentioned, our analysis is still a work in progress, but I really hope you were able to hear and identify in these stories how gender and gender norms play an important role in creating specific experiences as well as forms of work for women that are often invisible. We don't think about them. In addition to these norms impacting women's lives, of course, it's impacting their interactions with clinicians, with women being less likely to be legitimized or believed by clinicians, and more likely to be assigned the label of pain catastrophizing, as an example. Gender also intersects with race, sexual identity, poverty, gendered violence, and trauma in very complex ways. And so we clearly cannot think or speak about woman as a single category, but really need to do more and more work around how things such as racism, for example, influence women's experiences of pain and of healthcare. So these are sort of things that we need to keep delving into, I think, more deeply. And social theory and social science approaches can help us to understand the multiplicity of women's experiences and hopefully move us toward transformation of practice and policies. And I also just want to end by saying that understanding our own gender biases is a necessary but insufficient solution in this direction. We're all products of our society, and we're all shaped by the prevailing norms of our cultures, our positions, our social characteristics. And sort of through that mechanism, gender bias becomes normalized. It's often very difficult to recognize. And so a first step is sort of thinking more deeply about how we hear people's stories and what treatments can be offered in response. And really, I want to end by emphasizing the need for continued political action to try and address some of these profound systemic and social inequities that permeate people's lives, and in this instance, women's lives. So thank you very much for your time and attention. I did have a couple of questions that I wanted to ask of you, but I really welcome hearing your questions. I'm interested in how often you might hear some of these stories in your practices. I'm interested in how you might respond, interested in knowing people's own awareness of intersecting identities, what you'd most like to learn about gender, and what you think are the most important future areas of research. And with that, I'm going to stop my slideshow.
Do you know what I was thinking, Fiona? I will copy those questions that you had and post them in the chat, because those are really thought-provoking.
Yeah, thank you for that talk, and it just it makes me reflect on my practice and how did I listen to those stories and what did I do. And so really curious from the crowd, because I've had a chance to talk to you about those things.
Yeah.
If people want to share some of their observations and what they've done. Lori Montgomery.
I feel like I'm always the one to jump in first, but I was really interested in the clips that you had there about the discussions with women and their partners and how their partners support them or don't. And I know there's a whole body of literature around differences in communication between men and women, and which of course is very much about gender norms. But I'm thinking that it's interesting to me. We don't have very many objective tests in pain that can tell us what's going on with a patient. We rely very heavily on history. So use of language is incredibly important when it comes to defining what the diagnosis is, and then all of those things that surround the diagnosis that are going on with the patient. So I'm curious about whether that's part of your program of research, is looking at patterns of communication around pain, how people describe their pain or describe their needs to their providers, things like that.
Yes. So a focus on language is critically important to the work that we do, and we pay a lot of attention to what people say, how people say it. But we think of that more, not in terms of communication, but in terms of trying to link what people are saying to discourses, for example, more than thinking about it in terms of just communication patterns. I think what I'm sharing here today, though, are probably aspects of women's experience that clinicians often don't ask about. So there might be an assumption that a woman is getting support and care from her partner in the home, for example, if she is partnered, rather than an exploration of what really is available to her through her partner. But I think what you're raising would be an important area of study.
Anyone else have a question or comment? So let's see, I've got some in the chat here. Janetta, I don't know if you want to unmute and.
Oh, sorry, I'm a symptomatic close contact today, so I'm not very I'm not very good looking. Hi, Fiona. It's nice
Hi,
to see you.
Janetta.
And
Yeah.
thank you so much for presenting. And I came in late because I was seeing patients remotely, and that's never quite as efficient. But yeah, no, I mean, I think that I love just the intersection piece, and there's so much, like, I think this is the way of the future for primary care questions in general, those of us who are researching, but also teaching and thinking about it and reflecting on it and practicing in this space. So I don't know, I think it has to be embedded in everything we do. And obviously it's huge for me in substance use stuff as well. But my question was around just, you talked about political action, and thank you very much for that. And I just was curious what you're planning to do with this information, and the women whose brave voices are part of this, are they part of that process? And that was my main question.
And that is a great question, Janetta. So, you know, we're still at that. We haven't quite moved into the sort of mobilization piece of this research, but we do intend to, and we do hope to involve the women who wish to be involved, because, you know, it's important to engage our participants, I think, in knowledge mobilization and political action, but we also can't overburden them. And just sharing some of these complex stories, like Sophia's story, it's hard to imagine how she would possibly have the time to be involved in anything. But I think helping her to understand her own life in the context of inequities would be an important thing that we can hopefully bring to her, rather than seeing herself as deficient, insufficient, as so many of these women do. There is so much shame, there is so much self-blame that goes on in these stories, and it's profoundly difficult to sort of bear witness to that. And yes, we do want to be involved in whatever political action we can, and to support the political action of others. But there's lots to do, Janetta, as I think you said in your comment in the chat. It's overwhelming. You know, just the vicarious trauma of listening to some of these stories has been really profound for our research team, and it brings up so many issues, so many challenges to medicine. I have 3 primary care physicians on my team that I work with really closely, and they're the ones who identify things like the problems with and limits of diagnoses. You know, all the sort of social aspects of people's lives that get missed, the medicalization of poverty. There's so much in these stories, and so much to say about them. These have been the most difficult stories for me to analyze because of the complexity, and because often research requires us or asks us to pull things apart, and in fact we can't pull these things apart.
No, and thank you for exploring and teasing out that whole piece about the disability application, because I find it structural violence.
Yes.
So that's really important. Maybe we should talk offline about that one. But it is a horrible process, and I don't know if you're thinking about Dixon Wood's framework or anything about the hoops we have to jump through, but it's horrible. It's a horrible thing.
Yeah, let's definitely continue that conversation. We have a whole other analysis looking at more of those issues on the side to this. So, and I should also say that these are the stories of largely cisgender women. So there's so much we don't know about the gendered experiences of transgender women, of racialized communities, Indigenous women. It's there's a lot more to sort of explore here.
We have another comment in the chat, and I'm hoping I'm saying your name right, Knisha. I don't know if you want to unmute and talk, but yeah.
Yeah. I'm just, it's very interesting, and I feel a mix of emotions regarding all this, because I see patients in the chronic pelvic pain clinic as an obstetrician, and this is really hitting the nail. It's complex. You know, I have, as a physician, as a white person, a white woman, I also have biases, and it's just and they're unconscious. It's putting them in the conscious sphere that is sometimes a bit troubling when that happens. So it's it's a individual healing, but also a collective healing that's needed for these things.
Yes,
Thank you.
exactly. No, I'm so glad you said that. And also the reason I try to emphasize social transformation is we don't want to just keep treating and healing people and then having these issues come about over and over and over again in people's lives. And I think that's where some of the issues of intergenerational poverty, trauma, mental illness, abuse are so important. And that's obviously has tremendous relevance for Indigenous communities. Intergenerational trauma. Yeah,
For sure. And Chris had another excellent comment. I don't know if it's detailed in the chat, but I don't know if you want to unmute and just talk, or we can take a look. They wrote,
yeah.
Oh, you got it. Go ahead.
Just that I think it's a really important point that and because I've heard it from colleagues that women are quite often clustered in these pain conditions that are difficult to diagnose and difficult to treat. But I think the real issue is not that that's where women are. It's that these conditions that affect women predominantly attract less in the way of research focus and less in the way of research funding, which means that that issue of them being difficult to diagnose and difficult to treat is continuous. And that's exacerbated because we go, oh, well, difficult to treat quite often means it's a psychological manifestation. And then we over psychologize the issues that women have with pain. And that's encouraged by pharmaceutical vendors and psychologists who see that as a huge revenue stream for them.
that's exactly right. Thank you for saying that. Yes, no, exactly. And hearing the way women talk about themselves in psychological or medical terms when they're describing like situations of profound structural violence and inequity is it just over and over again. That's what you hear. Right, they've been trained to think of themselves a certain way, and I love what you say about, yes, we talk about these conditions as being sort of, difficult to diagnose, but really is that just because they're women suffering from it? Yeah.
This is a great segue into Lorraine's comment here, where she is pointing out that the problems and by default the solutions seem to be not in the medical community but legal, societal, policing, and just mentions, I see so many patients whose ex-husbands aren't paying child support. And we hear that all the time. And yeah, and what do we do as family physicians or as a nurse in that's limiting their management and their ability to get well? And so, and Lori put in another question. I heard Jeff Mogul, say recently their objections to his work on sex differences in pain because some people feel it undermines examination of gender differences. What are your thoughts on that?
Well, I think there's clear evidence that there are sex differences in pain, and so I don't think these things are either or. I don't think these things are in competition. I think the argument I'm presenting is that we need more of a focus on gender and gender norms and other sort of social aspects of experience. But I'm certainly would never argue that we should in any way overlook biological issues in pain. So that is where I would stand on that issue. But we have so much on the sort of the biological sex diverse side and relatively little on the gender side.
So I know you were asked about how you would use this research in political action, but there is a body of literature already. And how do you use data and research to inform policy or political action? And I see, Susan, you've got a question as well. I'll grab you.
It's a great question. I'm increasingly working with groups such as Pain BC, which is now Pain Canada, and I actually just have partnered with them on a SHIRT grant, looking at the engagement and research of people who suffer from chronic pain and are also marginalized. And the point of that work is to try and really move people to being able to be in a position where they can advocate for themselves and advocate for political action. So that's where I'm trying to move increasingly, is into those types of spheres and having those types of community partners and so many other community partners that we want to work with. So working with the communities who represent people from diverse groups. Yeah.
Thanks. And Susan.
I think I just sort of wanted to say I really appreciate your comment about hearing people's stories and what treatments we offer in response to that. I have the privilege of working in primary care from a social work lens. So I have the privilege of advocating for social determinants of health, disability, but I also see many referrals for cognitive behavioral therapy and those buzzwords, and I respect that treatment modality, but I think we really need to look at people's lives and look at that intersectionality piece and make sure we're looking at all of that, and being referred for cognitive behavioral therapy can further marginalize people and can send really terrible messages that I don't think can behave appropriately. Therefore, I am really screwed.
Yeah, exactly. Yeah.
So anyway, I really appreciate that you say we need to hear what they're saying and then take a look at what treatment is appropriate or what approach maybe might be the language that I take a look at from my lens.
Right. Yes. Thank you for that.
Yeah, thanks. Yeah, I think people's stories we need to pay attention to. And I really like what Janetta said. This is the future of primary care and understanding things in a much broader context. And so I really appreciate your talk today. Thank you everyone for participating. It was great to get all your comments and questions. And we're already coming up to 6 o'clock here. I just want to remind you that we do have a couple more CMN events before summer. We do have our ECHO. So June 1st and June 15th, if you have a difficult or challenging chronic pain case you want to bring to the ECHO, please take a look at the website. And then also on June 8th, we will be sponsoring a panel discussion about the meaning of empathy. We have the movie Access opening on June 3rd to June 10th. And so please join us to see this amazing film that did win the documentary of the year in the Canadian Film Awards this year. So it's the story of the novel approach to substance use problems on the Kainai First Nation down here in Southern Alberta. So if you're not a member of CMN, it's free to join and you can get on the list. And I've just been reminded that we actually are doing the University of Alberta Department of Family Medicine Grand Rounds, and we'll be presenting a mock echo there and talking about how we can use echo where all of us participate and learn from each other. So thank you very much for joining us tonight. And thanks again to Dr. Webster. It's been great conversation and really appreciate everyone's time. Thank you.